Thanks again to Consumers for Quality Care for supporting today's important conversations. A record number of Americans have health insurance, yet quality, affordable care continues to be a major concern. And joining me now to discuss what it will take to close these gaps in ways that are both effective and equitable, it's just a fantastic panel. Dr. Donna Christensen is a former member of Congress. She chaired the Congressional Black Caucus Health Brain Trust for 16 years. I feel like I talked to her a few years ago just as she was in there. And I love knowing that there's a Black Caucus Health Brain Trust, and she ran it there. She currently serves as a board member of Consumers for Quality Care, the sponsor of today's event. Amy Hinojosa is president and CEO of MANA, if I'm getting it right, M-A-N-A, MANA, a national Latina organization that builds multicultural collaborative networks to advance equity. And Dr. Sara Collins, who's an economist and vice president for healthcare coverage and access at the Commonwealth Fund. And for those of you who hadn't followed the Commonwealth Fund, they're like the kind of Wizard of Oz of health stuff. I mean, you kind of an amazing kind of global awareness, data, statistics, what's happening on healthcare around not just the United States, but the world. So thank you so much for being with us. Representative Christensen, it's such a pleasure to see you here and to be with you today. And look, I want today's conversations to really matter in a way where we're not just kind of lamenting again all of the gaps and mistakes. You know, part of it is an awareness of what's not working right. But I'd just love to hear from you, given your long experience, you know, on the side of decision makers, those who are voting on policy. What can civil society, what can our friends Amy and Sara and others out here do to try to enhance the efficaciousness, if you will, the effectiveness of the policy world on these questions? You're on mute, Donna.
Here I am. Okay.
Oh, there you are. Great.
Yeah, I think exactly what they're doing. They are the Commonwealth, which I've worked with when I was in Congress. We attended many of their sessions. Provides a vast amount of information that and they provide it to members of Congress and other policymakers. And in Amy's case, MANA is a strong advocate, not only for healthcare, but for all of the things that make up the social determinants of health. So I think we just have to keep doing what we're doing. But I think that they're doing their part, and we just need to keep beating the drum.
So let me ask you another question before I move to the others, Donna. You know, one of the terrains that we've been discussing is the huge levels of medical debt that insured Americans are carrying. It's just something I haven't seen discussed much of, and it's very, very substantial. Now, I know the Biden administration are coming into work like with 500,000 Americans. That's, you know, sounds like a big number. It's not in terms of erasing, you know, some medical debt at that level. But I guess the question is, who's the, you know, not to say that everyone has black hats and white hats, but who's the villain in the medical debt story?
Well, you know, CQC has been really looking at the insurance companies. As I think someone said in the previous panel, the consumer, the patients feel like they're being nickel and dime by the insurance companies because of the ever increasing cost of their out-of-pocket spending. And so that's one. We also look very closely at hospitals and whether they're being transparent, or how much they're charging. Are they utilizing their tax credits to provide charity care? And we look at medication as well. We've been very supportive of some of the legislation to reduce the cost of insulin, which Jim Clyburn mentioned when he was on. So it's a myriad of things, but we have been focusing on the problems that insurance companies and hospitals, for the most part, have been causing.
Thank you so much. Sara Collins, you know, I'm really, really happy you're here. And maybe you can tell our folks, too, where folks can reach the incredible amounts of data and research. I feel like I've been reading Commonwealth Fund reports forever. But we do have a question I want to start with. It's from Pinal Patel, who's a consultant with Botgio LLC. And she says, has the uninsured population in the United States actually increased or decreased from January 2020 to January 22? And what's attributed, if anything, to a shift? So I think it's an innocent question, and I don't know the answer to it. Do we have more uninsured people today than we did 2 years ago?
Actually, it was widely expected that the number of uninsured people would rise because of the pandemic as people lost job-based coverage. And what we've seen actually is that the uninsured rate has actually declined from a pandemic high of 12.3% to about 10.5%. So there's been an improvement actually in insurance coverage, and that is because people who did lose their coverage had the Affordable Care Act safety net to get covered through the marketplaces and through Medicaid. And the other reason is that we saw a major increase in the subsidies for marketplace plans that improved the affordability of those plans and led to record enrollment in the marketplaces. And then another factor was the continuous enrollment provision in the Families First Coronavirus Response Act that required states, in exchange for a federal increase in the federal matching rate, to keep people enrolled continuously in Medicaid over that time period. So we saw a record enrollment in Medicaid and the marketplaces, and a decline actually in the uninsured rate.
Sara, one of the areas that I've been wondering in is my own insurance seems to be changing every year. I have other people in this world. Is all insurance just insurance, or is there an unevenness out in the insurance world? Are there sharks or areas of concern out in the insurance world? Can you just paint a picture of how wobbly or secure our insurance coverage is in America?
We've made really big strides in making sure that people's health plans are comprehensive, that they are affordable. But there is a lot of work still to do. We know in employer coverage that people's premiums and deductibles over the last 10 years have risen much more quickly than their incomes, which means that cost burden is growing in their budgets. We also know that people, and we've talked about this, people have out-of-pocket costs that are high relative to their income. So even people who have insurance coverage all year have difficulty affording their health care. Why is it that a third of people in private insurance plans struggle with medical bills and debt, even though they are covered with comprehensive coverage? And we really need to start focusing in a policy way, in a very focused policy way, of looking at what the drivers are of this and why people are ending up with these big bills.
Thank you. Amy, I want to ask you about what some of the fault lines and cracks are in the healthcare system from your perspective. But we've got another question. I just might as well start with it from Teresa Martin of the Certified Diabetes Care and Education. She's a specialist there. What prevents payers from following evidence-based care is the question. Prior authorization interferes with quality. Why not demand prior authorization for non-evidence-based care? I have no idea what the answer to this question, but what I do know is that there are a lot of folks that look at the prior authorization world as another speed bump in this process that adds costs, that diminishes access, and gets in the way of this. And I'm just interested from your perspective as you're working with the Latina community, is this an issue for you, and what are your thoughts? You're on mute. There you go.
Okay, yeah. Great. So, what we're really looking at when we're talking, this goes to the heart of access to care, right? And even if you have access to care, do you understand the information that's being given to you? Is it being given to you in a way that you understand?
I don't. I don't. I mean, in my own case, I'm just going to have I don't even understand. So go ahead.
And you're absolutely right. So then when you add the layers, maybe an undereducated level, when you add a cultural level, when you add a linguistic level, right? So there are multiple barriers that are already keeping folks from even understanding the advice that's given to them. And that's assuming that they have care in the first place, right? As Sara mentioned, with the ACA, we've gone so far in being able to get folks covered, but we still have 30 million people, whether they're people of color, from underrepresented poor communities, who are still uninsured. And so even that barrier of access to care, we're just not even getting to that point. And I think when we have these conversations about access, we have to talk about who are we not reaching, right? And then what are the capabilities beyond that for them to even be able to have a conversation about what they should be doing in terms of their own healthcare decisions.
So what's the answer to that? Do you need to have greater uniformity in the provision of healthcare out there? Because it occurs to me, and I don't know Mana that well, and I promise you after this show, I'm going to dive in and, we're going to know each other for a long time and get to know, a lot more. But does Mana, has it thought about, helping to think about concierge services for the community you provide so that they have a place to go to help become more literate on these questions or issues? Is that too much of a burden? I mean, part of patient advocacy is actually helping to enhance their literacy in these issues, like you've said. But without an infrastructure out there, without folks to talk to, I'm not sure how you do it.
And that's such an interesting question. And this is the role that the federal government can play here, right? Because we've all heard of programs that provide funding to local communities to help with these types of things, right? Community serving, health organizations. But unfortunately, that funding isn't continual. So it's not considered something that is sustainable, right? So communities often have to take it upon themselves to fund community health centers that serve their communities, and then finding the healthcare professionals and the staff who are linguistically competent, culturally competent to be able to provide these services. But, the truth is that if you're someone who doesn't have access to care, oftentimes your first interaction with the medical community is going to be in an emergency room when you need critical care, and they may not have those wraparound and support services to even serve you properly.
Yeah, and I've been reading those emergency room costs are a huge, huge portion of this carried debt that people have, even if they have insurance. That if you look at how that debt is broken out, where it came out, is these emergency room moments. And, we've discussed some of that earlier in the program. Donna, I know that the Consumers for Quality Care and the board and your own work have looked a little bit at the kind of junk insurance industry. And could you tell us more about it?
Yes, and that's one of the reasons why people are finding themselves in medical debt and with high costs that were unexpected, because those are insurances that I consider them junk insurance plans, really, because they don't provide all of the basic cover benefits that should be provided. And when someone gets sick and they think that they are covered, they find that the insurance that they have just will not pay for the services that they needed. So yes, it's one of the issues that we have been very active on, and we've written to CMS and other, and also in op-eds about banning those short-term insurance plans and other junk plans. And actually, that's one of the things that the survey said needs to happen to lower the costs to them, lower their out-of-pocket costs.
Thank you. Sara, one of the basic political sensitivities in Washington right now, we don't get into the whole big thing, but you've got Senator Joe Manchin on, wherever the senator may be with regards to Build Back Better, but he says, look, we need to kind of help people where they're really at. We need to negotiate lower drug prices. We need to basically, enhance that. It's one of its highest agenda items in that. I'm interested in whether that element of a program translates into lower healthcare costs that people feel over time. And are there other things in terms of dealing with people in their pocketbooks that should also be on that agenda?
No, I think that's exactly where we should be looking. We are not looking as critically enough at prices, both drug prices, but also prices that hospitals charge insurance companies in commercial insurance markets. So this is a critical driver of healthcare spending. Spending premiums are driven by overall growth in healthcare costs, and the primary driver of healthcare costs are the prices that we pay to providers. So this is a very important part of the conversation. If we want to expand, for example, extend the marketplace subsidies, and Congress can do this, there is a cost attached to that. But we need to look at what that cost is. And that cost is driven by the prices that we pay for our services. It's not utilization, it is mostly prices. And so this definitely needs to be part of the conversation as we consider ways to address universal coverage, to get more people covered. But the prices are a very important part of that conversation.
Amy, I'm going to give you the last word, and I'm going to make this a tough question for you. I'm always interested in like stories that can be replicated or they, and I guess my whole goal in having these conversations with people is to find a day or a way where patients become their agents, have agency in their story, and they're not just victims, and you're either going to surf the wave or get clobbered by the wave. Are you able to share with us any vignettes of a story where you've been able to empower Latina women in a way where they were able to go from being victims to surfing their wave and in control?
Steve, this is so nice to be able to have this conversation, because we think that's absolutely the model of what MANA does. So we have chapters and affiliates across the country, women who are engaged in their community, who are trusted community leaders, trusted sources of information, and their entire mission is to make sure that they're sharing information and resources, exactly that, so that women have their own trusted sources, they have their own information, and then they have their own agency to make the decisions that they want based on the information that they have and that's available to them, and that they understand in their own language, in their own culture. And so, I think that to answer your question, MANA is the solution, right? And having women in the community who are trusted by other women to share that information and make sure that they're getting what they need, right? And because everyone thinks of things from such a personal level, when we talk about can folks pay out of pocket expenses and who's being hurt here, right? So 1 in 5 Latinas live in poverty in retirement. If the average, Social Security for women is $14,000 a year, for Latinas, it's $12,000 a year. And so, when we talk about formularies and how, decisions can be made around pricing, these are decisions that leave these folks out of the conversation. So in addition to that work being done at the local level and at the community level, what we do out of my office here in Washington is advocate for those policies here in Washington that help these women navigate these waters and to make policies that take them into account. And this is why we work with the Consumers for Quality Care. We work with the Health Equity Collaborative to make sure that we're raising these voices so that the answers are equitable across the board and that communities all across the board are able to get the services and the information that they need and the care ultimately that they need to live healthy lives.
Thank you. What a great conversation. I look, for better or worse, this is a perennial issue. We're going to keep covering this. My colleagues at The Hill are going to keep these discussions going. Hopefully they'll let me come back and play with all of you again. I would love to keep this conversation going. A big thank you to our panelists, Dr. Donna Christensen, a former chair of the Congressional Black Caucus Health Brain Trust, Amy Hinojosa, President and CEO of MANA, and Dr. Sara Collins, economist and Vice President for Healthcare Coverage and Access at the Commonwealth Fund. That brings us to the end of our program today. A very big thank you to Consumers for Quality Care for their support and to all of you attendees for joining us for this discussion. For those of you who may have missed any of the conversations, video from the event will be up on our website shortly. I'm Steve Clemons. Be well.